hospital discharge and managing expectation on a daily basis. So I'm going to pass over to Liz just to give an introduction. I think it's always important just to put everything in context. So Liz is just going to give a little overview about Angus. And are you changing the slides or are we?
No, I can do that.
Okay, so if you just move to the next slide, please.
Good afternoon, it's Liz Masterclass here. So just the first slide is what I've sort of map of Angus. And it's just to kind of demonstrate the kind of rural aspects of Angus and how widespread it actually is. The population of Angus is 116,520. It's split into 4 localities. In 2017, 1 in 5 people were over the age of 65 and 1 in 10 people were over the age of 75. By 2027, we expect that 1 in 3 people will be over 65 and 1 in 5 people will be over the age of 75. Next slide, please. Our community hospitals. So across Angus, we have 3 community hospitals based within White Hills and Forfar. Stracathro, which is it comes under Brecon, but it sits between Brecon and Edstall, and Arbroath Infirmary, which sits within the town of Arbroath. We have a total of 67 medicine for the elderly beds across the 3 units, all consultant-led, and in addition we have a stroke rehabilitation unit consisting of 10 beds which serves the whole of Angus, but situated on the Stracathro site. Within psychiatric old age, we have 22 dementia admission assessment beds across 2 areas and 13 functional non-dementia admission and assessment beds within one unit. The psychiatric old age beds are within the Stracathro site and within White Hills and Forfar.
Okay, just move to the next slide. I'm going to pass over to Dorothy to talk about a planning discharge. We're really focusing on discharge from our community hospital in Angus rather than from the acute admissions in Ninewells Hospital.
Hello there. What we generally do over the 3 sites between Brecon, Arbroath and myself here in White Hills is to do the same thing. So we'll go halfway down. Every Monday here in White Hills, but it's one day basis, we'll have a weekly multidisciplinary team meeting. And again, you can see who all comes there. At times we might have other people in like dietitian as well, but we focus on each patient in our unit and seeing where are we going with them. Do we set maybe a PDD at that time if it's appropriate? If they're not stable medically, we might put them under review, but we're all having a discussion of the planned care of that patient to try and get the focus to look over discharge date. Another point in the week, usually halfway through, we do on the Thursday here, we'll have a weekly board round, and again, you can see who's attending there, and we focus mostly on the discharge of that patient. It's not so much of the care that's going on day to day, but where are we, what plans do we need in place, what equipment do we need, do we need to do home visits, anything like that, we'll talk about that there, so we update again. At the bottom you'll also see individual family meetings for complex cases. I don't know about yourself, but we are finding there's more and more patients and families becoming more complex, so we're finding we're having individual meetings. So again, we invite the family along, the patient along, and we'll sit down with the relevant members of the team to discuss what we're doing for the discharge. It often throws up things we're maybe not been aware of before, of some problems at home that we might need to address or look at some options around reducing the problems or the risks of going home as well. And often then we'll get the family more on the side for looking at discharge as appropriate for that patient and individual. Okay, next slide. This is our ER team, it's enablement and response team, and they provide a short period of support for patients going home. Now the decision to go down to enablement and response rather than mainstream is made at the multidisciplinary team involving the social work as well and the family into this. They can also prevent people coming into hospital, providing support for them at home, assessing things, and as the word says, enabling people to give them confidence to get back to the task of daily living again. They also give support in with mainstream if somebody's already in mainstream and maybe want to reassess if they need increased package of care or just a bit more confidence to get back to the skills that was maybe lost over a period of time. And they're also very good at helping us with end-of-life care, which is quite a new thing for us recently as well. And some of it might be working closely with community alarm. For example, maybe doing a visit overnight for somebody who's maybe in palliative care but living alone and just does a check on them overnight as well. So it seems to be working well. Anything after 28 days has to go then to mainstream, so the enablement team might stay in place until then the mainstream services become available for that person. Okay, next page. This is a pilot that we are doing at the moment. We're asking relatives and patients. So the first question is aimed at the patient. What do we need to know about you as a person to take better care that we can of you? We'll make assumptions often about what's important to the person, but actually we get it quite wrong at times. And we usually try and give this out after 24 hours of admission. And for example, somebody said that they just wanted people to talk to while they're in hospital. And in a busy ward, that can maybe not be to the length that we'd like. So we actually got a volunteer to come in and sit and chat to the patient more. So they did that every sort of second day for them. So they felt that quite beneficial. And we do review to see if we've made that goal as well for the patient. And if we haven't, we then do look at a plan we need to put in place. We also decided with a lot of carer involvement, we needed to ask them what they wanted. So the second question about what do we need to know about the patient to help you, as well, to come to terms with the patient being in hospital, and that throws up a lot of things as well. Actually, what the patient thinks matters to them is not what the relative thinks matters, so it'll be quite different things that are thrown up for us to deal with. So again, it's sitting down with them, seeing what they think that we can help them with, and then we review that again before they go home at some point as well. So it's trying to see if there's any issues that we're not aware of before date of discharge as well. So I say it's just a pilot at the moment, so we've not got a lot of feedback from that at the moment yet. Okay, next slide. Questionnaire we hand out just when we've got the PDD set, the date of discharge set, we give to family members to see how they felt that we went in the ward again, about where they listened to, because that's a lot of things that families feel sometimes they're not being listened to and they're not being welcomed in. So again, we just go down these questions with them, we get feedback from them, and then we put improvement plans in place if we think we've actually missed something out. Also hits about making sure that we've given them Angus Carers leaflet or referred them to Angus Carers, so we're not missing that opportunity to have somebody progressed in there as well. Also, have they been involved about the discharge planning? That's always an important bit for today, to make sure that they have had a time to make their views known to us, and that they've been taken into account for the discharge plan as well. Okay, next slide. This is it's information we give to patients on discharge. We also give them to relatives of the request or the patient's got cognitive problems. And this is about all the services that will be in place for them going home. So it's all the services and everything that was agreed to at these meetings. So again, if it's private sector going in, what they're going in for, and we usually get time frames as well from the care management. So somebody's going in from, say, 8 to 8:30 to do personal care and breakfast prep. They might be back to do a meal prep at lunchtime. So everything's documented down so they know who to expect and at what time to expect them. District nurses, if they're involved as well. Any equipment that has to be in place, that might be toilet frames, that might be a hospital bed. Any equipment to follow in, that might be ramps outside or maybe rails to go into the bathroom as into the shower and things. That's not essential for discharge, but we'll follow up. Any appointments, if we've not made them yet, usually, if they're going to be followed up at MFE clinics, anything at all as well. So they've got everything there for the medication, who's doing that, the district nurses, family involvement. So everybody's quite clear about what's happening for the discharge. That's me finished my time.
Yes. Next slide. We've been working on this for a while, but we need another, or updating our discharge information leaflet that we're giving people when they're admitted to hospital. Just to manage expectations at the outset. So it details what to expect while people are in hospital, and also stresses why people can't stay in hospital, because as we know, some relatives maybe feel it's a good thing for people to stay in hospital. But we're just clarifying a number of things about expectations while in hospital. So next slide, please. I'll just pass you back to Dorothy to say a little bit about the electronic discharge document.
This is obviously completed for every patient being discharged from hospital, and it's obviously sent the day of discharge straight to the GP so they can look at the system within minutes of it being sent, rather than the old slow mail by envelopes and things. Also available to out of hours, so there's important information on that about maybe readmission, escalation treatment plans, also anticipated care plans, especially end of life where the patient would like to be cared for. So it's really as good as information is added to that to then go into the system for other people to look at. And again, all this should have been agreed with the patient, with the relative, what's the expectation if they have to be phoning GP or anybody after if anything does untoward go wrong medically, and that as well. Everybody's aware of what should be expected of the service.
Okay, and our last slide. I contacted my colleague in psychiatry of old age, the clinical team manager there, and I asked her for any specific points about hospital discharge planning in the wards that she oversees. And in relation to really all of the wards that she manages, she said it's important for people to understand at the outset that their relative has been admitted for assessment. This is for dementia assessment or functional non-dementia assessment. And ward staff will always be planning for discharge home where appropriate. And regular family meetings take place to discuss progress, to meet the team and discuss discharge planning arrangements. So there's ongoing discussion with family which is documented. And we've actually recently had some unannounced visits from the Mental Health Commission, and they were very complimentary about the work that goes on in our psychiatry of old age wards across Angus. So that's all from us. I know we've got another presentation too, so I'll let Alan speak now about what's going on in Inverclyde.
Thanks very much, Sally. I will just hand over to Alan now.
Yes, please, Sally. Hi, good afternoon, everybody. Thanks, Sally, for that. It was really interesting and very interested in your discharge leaflet. So when you finished it, I think we might just pinch it off you.
No problem.
That's great. I think one of the things which about communication, perhaps taking a slightly different tract, is to talk about the importance of communication within any complex system that we're working in. Good to move on. And I think it's just really the context is that we really have some clear visions and mission statements, and really about Home First is about that people are supported better and achieve improved outcomes provided in the home or community as close to the home as possible. And I think it's really important to emphasise that it's not about people paying lip service to that as an ethos for Home First or hospital discharge or community planning, but it's actually a recognition that it's the best thing, and it's not necessarily an economic decision, it's what's the best outcome for the individual. The next thing is really just maybe go through the sort of stages that we have. Early referral, we now have emailed to us from the wards, which has been a great help for us, about identification on the ward. We use our ECAN and our discharge nurses to help with the community work, and the community workers follow people into the hospital, so that if it is a known case in the community, it's not been allocated to a new worker to ask information again. There's a consistency of approach to that. I think it's really important at this stage is that we get the estimated discharge date. We're really pushing on that. That's one of our key aims for this year, certainly over winter. One of the other things we're doing now is about tracking the service user, because quite often in the past, we know somebody who's admitted to hospital. The next thing we'd hear is that they're now fit for discharge. So it's about making sure we are tracking people and making sure we know which ward they're in, and we're making contact with those wards, and more importantly, started the assessment process and the discharge planning. Rapid assessment process, really about proportionate assessment. It's really about how we can either restart cases, start new complex cases in the community, so that the real assessment happens post-discharge. This is really about making a safe discharge. The discharge planning needs to start at admission, as I say. We use discharge planning meetings, but also what we do have is our work is allocated to the key wards, the wards where we get most business from, if you like. And that allows us to come for early funding decisions so that things are set up for when the person becomes fit. This year, we're really going to be looking at delegated discharge, where the consultants we have only in a part of the week. So what we tend to have is a lot of referrals on a Thursday or Friday. And so what we're trying to do is get the delegated discharge approach taken up with the wards, and acute in the Clyde sector very keen to follow that through. We have to look at the direct link with the community, and what we have is in-reach staff who go into the hospitals. We've got in-reach district nurses, in-reach OT. They go into the hospital and help with the assessment on the wards. Communication, that's what we're here to talk about today, and really we've got it down as being crucial. We're just to acknowledge we're in a very complex system. The service user involvement is part of that, care involvement, unnominated person, and I think very often the service user and the carer are lost within the system. We need to keep on that. And also what we're looking to do is discharge to home. That's the whole emphasis about home first, and that's the message, the cultural change I think we've made grounds on in Inverclyde. I don't think we've completed that, finished that in any way, but we are getting that through in the process. The next slide, I'm going to have to find a new slide because I've used this too often now. We've seen this a lot, but really it is about saying there's no shortcuts with this. This is hard work. It's focused work with a plan and being very clear what we need to do. We can't just think, oh, it's quite easy. We produce processes, procedures, we produce information for people. It's more than that. Okay, and quite simply, it's about talking to each other. And I talk about all this, that's what all communication is about. It's about getting the key people talking to each other at the right time. Sounds easy, doesn't it? There's a cultural change, and that starts the conversations. Like to the talking points methodology, it's all about having a conversation with service users and partners. And I think that's really what it is, about using the methodology out there and adapting it for our uses. Encourage local solutions, ward-based solutions or community solutions. Let the staff on the front line come up with the answers to some of the problems. I talk about plan, do, study, act. But I think the trend now is to call it tests of change. So just create a test of change on a ward basis. Knowledge that leadership is at all levels, and we get great leadership from some of our nurses on the wards and some of our social workers, social work assistants who come up with ideas on how to improve things. Identify champions, but what I've learned is don't necessarily tell the person they're a champion. Some of them get very stressed about it, and some of them get very anxious about it, but actually what you need to do is say, there's a person who's doing a really good piece of work, we need to get people to model their behaviour on that individual. And the next thing is about the vision, which I've spoken about, and the brand. And the next slide really is about our home care vision, and this is one we've agreed, we've worked up with service users, we've worked it up with staff members, and it really is about saying, when we talk about home first, this is what we mean. And it's about planning social care support around the individual. We have aims to discharge all service users within 72 hours of being fit. What we want to do is discharge people as they become fit. Reduce number of people identified as late discharge, and ensure staff are empowered, but also work with stakeholders to improve outcomes for vulnerable adults. And this is where we come back to planning for discharge starts in the community, and we need to work with the groups we have. The next one is the brand. I know it sounds silly, but everybody knows what Home First is in Inverclyde who work in health and social care. And although we coined the phrase, we thought it was a really good phrase, and we thought that's great, people understand what we mean by it. I've had it quoted back to me by service users. I've had it quoted to me back by staff on the wards, and it's great to have that. But it was when Alan Stevenson started with us, and he said, you just need to brand this. You need to have something that people will recognise as Home First. So we have our Home First logo. We've extended that to have Home First enablement. and that's the one with the wee house and the leaflet on the side. And also we've got a single point of contact we're developing. It's access first, and it's creating that understanding and a theme so people understand what the aims of the work we're doing is and what the teams are meant to be doing. Okay. So communication, I think we all get it. It's a common language. That's what we need. The old adage about people who should be referred for assessment, not for long-term care. We still have this. We still have this all over. People referred for the service rather than for assessment of their need. So it's about ensuring we have the common language. What do we mean by complex care? What do we mean by complex situations? What do we? And it's things these we have to have that conversation with each other, with other professionals, so we have that understanding what we're talking about. Communication needs to be accurate, understandable, and timely. And that's really the message about information and communication. And simply, we also need to think who needs to know and what do they need to know. And the context for that is that we're in a fast-moving, challenging, complex, changing system. It really does. And what works in one situation may not work in the next. And so we have to be flexible and adaptable to that. The next one is about when to communicate. And this is, again, we're not saying this is about how, we're not going to give people a script. This is what you need to say, this is when you need to say it. But it's really about looking at your situations and the context you have. But what it is important, it's crucial to plan ahead. And we need to ensure that significant participants, and we need to know when to talk to them, what we need to talk about, and to who are we going to talk about. And we need to plan that. And if we get early referrals, discharge, an MDT, we can identify housing as a problem, for example. Getting early talking about housing rather than at point of discharge, realise somebody can't return to their own house. Are we looking at a short-term admission? What are we looking at for that? The referral, it's about accurate information. Last week I heard again about people getting referrals saying, oh, there's Mr. Brown, you need to go and see him because he needs to go home. And that was the referral. We have systems in place. Everybody keeps to the system, but what we're saying is we need accurate information. The better information we get in the community about somebody, the quicker, the smoother the discharge process. We need to track the service user. We need to track them through the system. We're looking at a frailty hub, and that again has come out of the organisation we've had and the procedures we've put in place, where actually we've got a mixture of social work, acute staff. We're going to be working together to track people through the process and track them through the discharge process. We've talked about rapid assessment. Discharge planning is crucial, and that's where the communication is essential. Everybody's involved in that. Some of the features, we have a daily huddle in Glasgow and Clyde, but also in the IOH, we have one around the Frailty Hub as well, which looks at the people who've been discharged that day, ensuring things are ready for them and who's coming up. We have a operational meeting, which is once a week between the ward managers, team leaders in the community, and they again look at who's coming up for discharge. And we ask this all the time: who have you got that in the next 7 days is likely to become fit? So we can plan that change. And that operational meeting is successful, but every so often we have to go around and remind people they need to attend. We also have a 6-weekly interface meeting where it's managers, Alan Stevens, head of service, and the acute general managers, and we meet every 6 weeks and look at the process and look at the common issues. And that's where some of the issues we've sorted out on the Frailty Hub, the emailing referrals, and the communication and the culture about who takes the decision discharge. It's been really useful to have that, and would certainly encourage people to have those meetings on a regular basis. Okay. So the next slide, I'm not going to go through this. It's really about who is involved in this, and I think we could have written 4 or 5 slides of the people who should be involved, but it's about being aware of the holistic system and who needs to be involved in the whole discharge process and at what stage. And coming to the end, is the next one is I was just going to leave a blank speech bubble here, right? Because quite often you can see that we talk about communication, but nobody's listening to what anybody else is saying, right? And everybody's talking and nobody's paying attention. And the effective communication has to be relevant to all participants. It can't just be that what suits me because I want my discharge stats to look good. I want to reduce the discharges. You've got to think about everybody around that table, everybody in the process requires to hear what are their needs for that. So summary, and this is something I used previously, It's really about its whole system approach. It's the acute and community working together. Care and planning needs to be person-centred, has to be focused where the person is. Discharge planning starts in the community, and we're doing that with anticipatory care plans. We're doing that with our step up at home services. It's a cultural change, and a decision needs to be taken about once the person is fit. And we have an issue with that, where we have people talking about people going to care homes, and it's about being clear that actually the HSCP and the family will decide where the destination for people is. But there's a big cultural change, and it's still ongoing. Risk management, there's different levels of risk in different services. We have to have communication about that to understand what the actual risk is and who's holding the risk. It takes time to show sustained improvement. We've been doing this, we've been saying this is years I've been in Inverclyde, and we started this 5 years ago when I arrived, and a lot of the progress we've made has been sustained. There's not one quick solution to this. Advice is that you start at a ward or one consultant at a time. You pick who you want to work with, you push at an open door, and you get success. And once you're successful around these areas, around good communication, other wards and other consultants will want to buy into that, and so will other teams in the community as well. And the final thing which I always put in is that you have to have community resources to receive the discharges. If you don't have them, discharges will not work, will not happen. Okay, thank you.
And thank you very much, Alan, and Sally and Inverclyde. Now, does anyone out there have any questions for either presenter? Either unmute your mic and speak, or you could put something in the chat box. Okay, if no one has any questions, then we'll wrap it up. As always, we have recorded this session, and it will be available on YouTube for anyone to watch again or share with your colleagues, and we'll put a link around that once I've uploaded it. So thanks very much for tuning in, folks. We'll just sign off now. Thank you.